Okay, so switching gears to Arizona. And I first want to have a shout out to Dr. McKeon, who has been an incredible champion of this work over many, many years. Acknowledging a huge and incredible team and wonderful funding partners. So I'm going to give you a little bit of background on the White Mountain Apache tribal community and then the tribe's incredible response to a suicide crisis and associated data that kind of marched through the response and what the results have been. So the White Mountain Apache tribe lives in a beautiful alpine high meadow area right in that central eastern Arizona. About 17,000 enrolled tribal members governed by a 11-member tribal council. They just elected their first chairwoman. Johns Hopkins University and our Center for American Indian Health has had a continuous 38-year relationship doing research, training, and programs with the community. So suicide rates prior to 1950 were very low. That's true in all American Indian, Alaska Native populations, which is what makes this research so important. What has changed? What can we learn? Began to see spikes in youth suicide in the late 1980s, and those have continued until the present time. Large community strength, some tribal sovereignty. As you know, tribal federally recognized tribes have a nation-to-nation status with our federal government, so that gives them some autonomy over certain types of legislation related to tribal governance. Family is largely the center of culture. Large family networks strengthen the community, and yet over time, through a march of policies and other social ethnocidal events, family networks have really been degraded by a lot of things that have happened, from boarding schools to forced relocation to incredible marketing of alcohol to tribal communities. Traditions support the sacredness of life and youth, so a lot to tap into there. And there's really strong capacity to adopt, adapt, and diffuse new innovations. So in 2000, there were 11 deaths in a 6-month period among youth. And the tribe was at a real loss of what to do and decided, knowing nothing about what the country was thinking about in terms of response, they mandated suicide surveillance in a registry system. At the time, it was a paper and pencil system. Writ large, it was that everybody who knew of any sort of suicidal event had to use a certain form, write it down, and pass it in to someone who sat at the Indian Health Service. After about 4 years and stacks of papers, the tribe asked if our center would help with building out a computerized registry management system and to report trends on a quarterly basis and begin to help think about how do you respond to these trends that were coming in. So today, this system has evolved incredibly, so it's now formalized so that all persons, departments, and schools are responsible for reporting individuals at risk for any self-injurious behaviors. And the reportable behaviors are broad, and it's really exciting as we've talked about the role of alcohol and drug use overlapping with suicide. So suicide, death, attempt ideation, non-suicidal self-injury, and binge substance use are all mandated reportable behaviors. And then these behaviors are followed up on by a team that's called Celebrating Life, and I'll tell you more about them. And then they make a referral based on the preferences of those individuals to local services that could range from the local behavioral mental health services to traditional healers to churches. I want to show you the original surveillance measurement tools. So this is what's called the yellow form. That's the intake form, and that just shows you, it's a one-page form, and I don't have it all on there, but I wanted to give you a sense. But it just collects basic information about the incident, the person, and some demographic details. And then the case managers, when they follow up, they fill out this pink form. And the pink form is much more detailed. It's 6 pages long. It goes into great detail using the Columbia rating system to understand what type of attempt was it. Was it an aborted attempt? Was it an actual attempt? So classifying these events very carefully so that they can be sorted in terms of imminent risk and categorized by different demographic features. This is a group of amazing people who are the local case managers. They all started as paraprofessionals, and people really argue about paraprofessionals at meetings I go to because they feel like it's an end-stage career plan for someone. And that couldn't be further from the truth in communities with unemployment rates of 80%. So these were really motivated individuals who, more than 12 years ago, decided that they were going to, put their hearts into this work. And they've all gone on to get greater education. And Noveline Goklish on the far right and Francine Larsler in the middle just completed their master's in counseling and are now enrolled in a PhD program at Arizona State University. So it's a ladder for development. So let me just show you what the surveillance system was able to reveal. So this was for a 6-year period, and you'll see that the rates for the total White Mountain Apache population were 40.1, so very similar to Alaska. But those rates for the 15 to 24-year-olds were 13 times U.S. rates, so an astounding problem in that group of young people. That was also true of attempt rates. So I'll tell you a little bit about the death rates. So the highest death rates were for 20 to 24-year-olds. The highest attempt rates were for 15 to 19. So we're seeing accelerated risks as people age into young adulthood. We talked about male and female ratios before. Males were dying at 6 times the rate of females, but the attempt rates were very similar, which was different from patterns in the general U.S. population, where females were attempting at this time at 3 times the rate of males. This has changed, so that's what's so great about this tribal-specific data. We've seen big changes in these ratios. So then we said, geez, how do we learn how to stop this? So the thing the tribe that came up with was, let's talk to youth who've attempted, because if they tell us what were their circumstances, we'll learn what to do to help them. So this was a trial that was supported by the Native American Research Centers in Health, where 71 youth got a one-time in-depth quantitative assessment 30 days following a suicide attempt. That attempt was coded, they had to require medical attention. And then a subsample did qualitative interviews every 2 months for a year. So here's what we learned. So 29 of these youth completed the DISC, the Diagnostic Interview Schedule for Children, and we didn't find anything really incredible or remarkable here. I highlighted those diagnoses that were endorsed at a rate of 30% or more the youth endorsed. So you could see here that there was more endorsement of anxiety, separation anxiety, agoraphobia, conduct disorder, alcohol dependence, and marijuana dependence. What else did we learn from the youth who attempted? So these were the precipitant reasons that they said triggered their attempt. So more than a third, family problems. 19% said they were angry or depressed. 16% said they had relationship problems. 15% said they had a recent suicide death of another person. And 22% said nothing. And we were really curious about the nothing. A lot of times nothing came after someone woke up from an incredible alcohol or drug use binge and couldn't remember having attempted. 64% got referral to the local behavioral health systems. 60% actually ever got there. So that means less than 40% of the total who attempted ever got any medical health care. And then an incredible role of substance use. So 68% of deaths ages 20 to 25 were confirmed drunk or high at the time, but the majority of the rest were unknown, so we suspect it was much higher. 44% of the youth who attempted were drunk or high, and that was not their primary method, but when you add in their primary method was an overdose, then nearly 70% were using drugs or alcohol as part of their attempt. So huge problem. 79% were related to alcohol or drug use. Oh, and one thing about the means restriction, 90% of deaths to this day are from hanging. So means restriction is not a good public health solution in this community. So this is from the qualitative interviews, just to kind of understand what do we do to help these youth. So a lot of impulsivity and reactivity just happened out of nowhere. I didn't think about it. I just took off and tried to look for that rope. Family dynamics, I would have to say that our relationship is a boat and it's got holes in it and we're both trying to haul out the water. Excuse me. So we don't talk like we used to. Substance use. My mom was hardly ever around. I always knew what she was doing, even when I was about 4 years old. I always stayed with my grandma. I always wanted to be around my mom when I knew she was trying to quit, and it wasn't that long before she would take off and drink more. So the tribe, over this period of time, recognizing both non-suicidal self-injury and substance use was part of the problem, it continuously expanded the mandate for reporting. And now they have this incredibly broad prevention program that is across universal, selected, and indicated areas, which we've talked a lot about. And there's a very robust, both a community advisory board and an elders council that guides this work. So just briefly, this is a list of the universal activities, public education campaigns, suicide prevention walks, door to door. They literally go door to door once a year and ask family members if anyone's suffering from suicidal thoughts. Then in the selected and indicated areas, they have what we know as gatekeeper trainings, but they didn't like that word. They call it caretaker trainings. Cultural and strengths-based activities that are led by elders. There's a curriculum now that's taught monthly in the middle schools by elders. And there are 2 brief interventions that have now been designed. We have good pilot data on both, and they're now part of an NIMH trial that is a SMART trial of trying to understand if these interventions alone or in sequence with case management or just case management alone reduce suicidal ideation and attempt. And the brief intervention for elders, the elders component came straight from the elders curriculum that was designed for the schools. So just a snapshot of the evaluation we've been able to do over time, and this gives you our methods. I want to keep going in the interest of time. But this was an article that was recently published in the American Journal of Public Health. But you'll see on the left-hand side for the period of 2001 to 2006, the red bar is the death rates in the White Mountain Apache tribe compared to the all-American Indian Alaska Native rate, the U.S. white rate, and U.S. all races. And then the 6-year period following this very comprehensive community-based approach, 38% lower death rates when the other rates were staying the same or slightly increasing. And then in the same period of time, this is a look at the suicide attempt rate. So we think we're even having, this solution was having even a stronger effect on attempts. Very hard to compare these to general U.S. populations because this kind of data isn't collected in the same way. So just to conclude, these comprehensive prevention approaches appear to be helping and working. Serious mental illness is probably playing a less significant role in terms of the driver of these disparities in Native communities. Role of substances is huge. We're seeing more that young women and young parents seem to be at increasing risk. That's a little bit of data, but in recent years, nearly half of the deaths have been females, and many of them have been young mothers. So this is a huge worry for the tribe, and you can imagine why. What's protective? Jim mentioned some of these things, but age is protective. The older people get, the less suicide risk there is. School is protective. I didn't get to show you all this data, but there are fewer attempts, deaths, and binges when youth are in school and have low truancy rates. Culture is protective, not just against suicide, but against substance use, against sexual abuse, against many other things. And task shifting, I really think, is the way of the future for all populations in the world. We need people to fill these gaps who are going to have this caring communication and who know the people from their own emic background. So thank you so much.